everyone. Thank you all for joining us. I'm super excited. My name is Dr. Laura Fortner, and I'm your longevity doc, doing holistic care based on your DNA. And I'm super excited to have a special guest today. We have caught her in between hospitals, and it's Dr. Alexandra Kharazi, and she is a cardiothoracic surgeon. I'm so excited that she's agreed to speak with us today about women, heart disease, and all the things. But what I would love is, Dr. Kharazi, if you could just share a little bit about yourself, where you're at, what you do. We'd love to hear it.
Hi, Laura. Thank you for having me. I'm Dr. Alexandra Kharazi. I'm a cardiothoracic surgeon in private practice in San Diego, California. I'm also author of the book of The Heart of Fear, and I have a consulting business as well.
Tell us a little bit about what you're doing right now. Like, you're in the middle of your workday and we've caught you. I've snagged you for a moment. I would love to hear about your workday a little bit.
So as a cardiothoracic surgeon in private practice, I have privileges at several different hospitals around San Diego. So oftentimes during the day, I go to different hospitals depending on where the need is or where the patients are that I need to see or the cases are that I need to do, the operations that I need to do.
I kind of want to just really hone in today on women and heart disease. And I would love to hear some stats that you have, your patient population. How many women do you see in your practice, age ranges, that kind of thing?
So I'm so glad you brought this up. This is coming at a really good time. As you may know, February was actually American Heart Month. So I've done a lot of work with the American Heart Association to really spread awareness about women's heart health in the San Diego community. This is important because cardiovascular disease is the #1 killer of men and women in the United States annually. It actually kills more people than all cancers combined. But in women, this is particularly insidious because women tend to present at a later stage of their disease. And that's because a lot of our symptoms are atypical. So a lot of us don't just present with chest pain, which is recognized as the most common symptom of heart disease. A lot of us present with other vague symptoms. And so because of that, they're underdiagnosed and misdiagnosed. And we're much more likely to be diagnosed with anxiety disorders or gastrointestinal symptoms. For example, a symptom such as heartburn may actually be a sign of heart disease in a woman, and it's especially somebody with risk factors. So a lot of the work that I do outside the operating room focuses on spreading awareness in the community and educating women, especially about knowing their risk factors for heart disease, right? So what are the risk factors for heart disease? So most commonly, high blood pressure, high cholesterol, smoking, obesity, and family history. So if somebody has all of those symptoms, they really need to be more aware. You know, there's a reason that high blood pressure is known as the silent killer. A lot of people are completely asymptomatic. And then when they do present, it can be with a very serious complication.
Yeah, for sure. And what kind of age ranges do you see with women? I mean, do you see young women or are they mostly menopausal?
Most commonly, they are menopausal or they are in that older age group. Heart disease can really present in women even in their 20s, particularly if they have risk factors for heart disease. It can really affect, cardiovascular disease can affect women as early as late 20s and early 30s. And so this is actually a good time to plug into the importance of heart health and plug into what your individual risk factors may be and how the path to preventing heart disease starts now, Laura. And I think that this is exactly why I do the work that I do. As a cardiothoracic surgeon, I often see people at the end stages of their disease, right? So what do I mean by that? So oftentimes when I see people coming out of the cath lab with a heart attack, right, like a massive MI, it's been years and years and years of disease that has built up, right? I'm getting to them. And of course, we do the bypass and we fix those blockages. Same with an aortic dissection. A lot of my patients who have had aortic dissections, which is a surgical emergency, it's a high mortality rate. An aortic dissection is a surgical emergency. When I see those people, a lot of them have had high blood pressure issues for years, and that has potentially not been followed, or people haven't known how important it was to follow, or the complications that can come from that. But a lot of it had started much earlier. So I am starting to see like a very young population of patients come in with these issues. So for me, I was able to fix those problems once they got to me as a surgeon in the operating room. But a big part of me was unfulfilled because I felt like, isn't there more I can do? Like, what more can I do? So for me, it was important to go out into the community and to like educate people about the risk factors for cardiovascular disease, to hopefully nip that in the bud, so to speak, and to hopefully get to people, not just on this end of the spectrum where I'm seeing them in the OR, but also early on when we can still make a difference and potentially prevent one of these complications.
Yeah, and I think you brought up such a big point right now, especially now more than ever. We're seeing younger and younger people with obesity, insulin resistance, and these things amount to an increased risk in cardiovascular disease as they age. And one of the things with longevity medicine, right, is to really capture these at-risk patients and the awareness that these things start early. And even though they may not see overt symptoms or have a heart attack per se, right, they can do something about it now. And I think one of the things that I do that has been so rewarding for people is to really check their epigenetics or their DNA and really look at what their risk is as they age and what things they need to be watching out for. Do they have certain DNA SNPs that are associated with like LP little a or cholesterol and cholesterol issues, or inflammation? Those types of things we're looking at in the deep cellular level, and we can tell based on someone's DNA they're at risk factors as they age. And when a woman, especially me, I'm going to just use me as an example. When I went through menopause, okay, my cholesterol went up significantly without me doing anything. And we know that those hormones are protective at a younger age. And this is why these gals in their 20s and 30s, maybe they have some increased risk of heart disease and might be starting some calcifications or something going on, but they don't really get into a significant issue until they come to you or you're seeing them on the other end of the spectrum. Hormones are protective in some way. We know this by many studies. And as we age and get to that second half of life is when overtly things really start to happen to us. And like you said, it's silent in many women. And I don't know, I can't remember the statistic now of, that first heart attack, what's the likelihood of the mortality of that woman?
I think it's variable and it depends on so many different risk factors, but I wanted to just kind of piggyback off of what you're saying because it's fascinating. I just saw a patient in clinic and she is at that stage of her coronary artery disease where she's going to need a CABG. So coronary artery bypass grafting, I'm going to have to open her chest and do bypasses. And she's in her mid 50s. What's interesting is people always ask me, well, what are the risk factors? A lot of the questions that they have revolve around their kids or their family, and do they need to get screened? And what I say is all roads lead to Rome. That's kind of what I say. I say that there's multiple different risk factors and you have some combination of it. So some people, it may be predominantly high blood pressure, and some people it may be predominantly high cholesterol. But basically, all of these things combined in some percentage or in some combination lead to this type of disease. And that if we let that go on long enough, particularly women are vulnerable to this because, we're more likely to be asymptomatic. It progresses to this end stage, which means that you need a procedure, or I should say it leads to this advanced stage where we need a procedure or something as serious as an open heart surgery to correct that. But what struck me as fascinating about what you're saying is actually that you're telling me that now with DNA testing and what you do, like we can figure out what those percentages are. Because right now I'm just telling my patients, like, it's hard to say what percentage, how much blood pressure was contributing. It's hard to say how much high cholesterol was contributing. All we know is now we're here. But it would really be helpful, I think, if people knew like that they're prone to these things. Is that what you're telling me? Are we
Yes.
coming to that stage in science where we can tell this, and where I can, if one of my patients got DNA testing, for example, then she could potentially know that she's really prone to high blood pressure specifically, or that she is prone to getting high cholesterol, that we could target those specific risk factors.
Yeah, which is really incredible because it gets down to the deep cellular pathways. So our DNA instructs our cells what to do. We're trained in medical school, right? Like to know the diagnoses and what the risk factors are. And those are sort of the external things that we see, right? They're not the deep cell pathway that's getting affected. So what's so interesting about DNA is that we're able to say to someone, okay, you have, for instance, the LP little a DNA SNP. There's several different SNPs of that DNA that has to do with that pathway, LP little a. And we know that those people that have variants in those SNPs have a much higher risk to get cardiac disease, arterial stiffness, and calcifications and that kind of thing. And we are able then to go down to that cellular pathway and say, we know based on science that certain supplements, aspirin, even I think it's the PCKS9 meds, even those meds, we know those meds work on those pathways. Supplement wise, when they're young, a little bit of a prevention of talking to them about nutrition, diet, and then really talking about supplements that really help to keep the arteries flexible, right? And not stiff and open. So that's just one instance. There's multiple DNA SNPs that we test for in our cardiac panel that we look at. So that's just one of them. But that is what's so interesting about the whole thing, because you might not have, like in me, I don't have the LP little a DNA SNPs at all. So I'm not at risk in this way, but I do have problems with cholesterol metabolism. So, and that's with the ApoE4 gene, which is something totally different. And that pathway is treated differently. And it actually has different diet and nutrition along with it. So it's very interesting what we can know now. And people, the sooner the better, I think, in getting these tests, because these tests are, you get it once, you can optimize it forever. So you can always go back to it and reference it when the next thing comes up for you, if you get the entire sort of medical DNA genomic panel. So it's mind-blowing, revolutionary, and it will, I think, change the face a lot of what we do if we can grasp onto it as a medical community. But I know in the traditional sense in medical school, and like you and I, MDs, DOs, we are trained in a different way.
Laura, I think as a cardiothoracic surgeon with a specific interest in women's health, what I'm hearing is that this might actually narrow that care gap between women and the healthcare world right now, because as you know, or as you may know, a lot of the early studies in heart disease were done primarily on men. So a lot of the symptoms that we have and a lot of the treatments and a lot of the results of these studies that guide our current management as clinicians are studies that are not based on women at all, right? But here we now have this opportunity to get DNA testing, which may then, without kind of bypassing that system, kind of bypassing potential misdiagnosis or underdiagnosis, be able to give somebody their specific profile to be able to know what to look out for, even in the absence of symptoms, and that is what creates a lot of that care gap. Because in my patients who are women, because so many of them are asymptomatic, I had a woman recently that had been diagnosed with panic attacks, and really she had severe coronary artery disease, and her only symptoms were she just didn't feel right. Like something wasn't right. Like she had sensations that just weren't right. But it was getting put off because she was otherwise healthy and she was in her early 40s. And so she multiple times was turned away, and it was brushed off as nothing. And then she turned out to have severe disease. And so this creates not only a care gap, but also a trust gap, because I think women are less likely to trust us as clinicians after being through the ringer, underdiagnosed and misdiagnosed. And by the time they do present, it may be to treat the sequela of heart disease. Like, for example, they may have a low ejection fraction by that point, even though that could have been prevented. Like had their heart disease been diagnosed earlier on, then their heart wouldn't, their heart muscle potentially would still be viable and they wouldn't present at such a late stage of heart disease where, now they're having shortness of breath and now they're having the leg swelling, these heart failure symptoms. And because up until then, they had these mild vague symptoms or were completely asymptomatic. So with a test like this, if this is available publicly, then anybody can just know that they have this predisposition. And maybe this would be something that could cause them to investigate further. Then we could be catching women, which is really what we're striving for, right? Is to catch women at earlier stages of disease so that they could have better outcomes with the kind of procedures that I do as a surgeon. If you catch them at earlier stages of disease when things are still relatively well preserved, then they will have a better outcome, regardless of what invasive procedure they have to undergo later on, or just prevent that altogether.
Yeah, I know it's exciting to think about. I think it's just not known out there, right? It is available. Right now, it is only, insurance doesn't cover it or anything like that. But I think of it as a tool, literally life-saving, and especially for women. You brought up a huge point that women haven't been studied. Science, medicine doesn't know women in really true essence. I mean, I know we're bringing an awareness to this subject right now, but it is one of those things that we need to know. We are biologically different than men. Our hormones are totally different than men. As we age, yes, there's a lot of talk right now of women going on hormone replacement therapy. And I think if they're a good candidate for it, yes, it will help them with cardiac disease, especially if they start within an early window through the transition of life. But that's not everything. That's the thing, right? Like, there's not one all end all be all, but putting it all together, having this data on yourself, I call this DNA data the encyclopedia of you, because it really is you. It tells you why you're different than everyone else and how your body is going to function optimally compared to someone else. And we can look at this early on, 10, 15 years prior to even getting to menopause to really know what you need to do to optimize your health so you can have an easier transition and really prevention. And like you say, getting the disease outcomes are going to be so much better if you catch these people so much earlier. And I do think that one of the pieces of medicine that is an old school that we have to throw out is this whole concept of we can't treat anybody or help anybody until they have a diagnosis. Like, we need to get better as clinicians to start prevention and really make that full scope prevention, not just a little bit here, a little bit there. Like, I think we need to look at us as whole human beings with multiple systems and different cellular pathways we have the same cellular pathways, but they don't all work the same. They're not all optimal. The science of epigenetics is you are able to change the expression of those genes. And when you change that expression, you can absolutely, that mother that died of a heart attack at, 55, you think you're doomed, you're not doomed, right? We know this.
Well, and I think to your point, right, people really don't trust us as clinicians, especially after COVID. Like, the landscape has really changed. And I think it's because when COVID came upon us, it really highlighted that there's so much we don't know and that guidelines were created that were not necessarily able to be studied. It really created a rift in the community and clinicians. And I think that putting some of that back, empowering people with their own information is going to be a huge step in prevention, because there's very much this narrative of us. And particularly because, like you said, the narrative right now is we need to get a diagnosis. But because of that, the narrative has also become in the community that we're just doing procedures, right? And it is because we're catching up on the back end. So I think any tools we have to give back to the community that can be used as prevention is going to be huge in terms of narrowing the trust gap.
Yeah, taking charge of their own health and empowering them to equip them. What's so interesting about this DNA test is when they know, it's almost like, I don't know, for me, it was like a switch, like my body will work so much better if I do this. And when I do it, I feel really good. So that just perpetuates the habits of whether, my diet or my lifestyle changes I've made, some supplements I've made change to, like all of that matters. And when people know, they do better, right? But when they don't know, everybody's put in this sort of box, right? And we are guessing in some ways. This is getting to the root of everything, and it's revolutionary. I'm excited to maybe pair up with you and help some of your cardiac patients, and maybe we can talk about how we could possibly look into a little study or something like that. I think that that would be powerful. And I'd love to also hear like what you think is sort of up and coming in terms of what we could do as clinicians as well. I'm talking about DNA, but what other things could we be doing as docs?
Yeah, no, I think that's a good point. Well, first of all, I'm getting my DNA done, and I already have so many patients that are asking me questions about things like this. They're asking me, like, is there anything that else that I can do? Is there any other information I can have? And there's so much misinformation out there, and everyone's creating an app, and everything is there's just over analysis paralysis, decision paralysis, right? And people just want to, know, like sift through all of this. So they're still coming to us that they're seeing that who they trust, like my patients who I operate on, obviously trust me, often asking me for what's coming out. And I tell them that this is a technology that could potentially help. We did catch one diagnosis early, like heart disease, which is why you're here seeing me after your heart surgery, but it doesn't mean that there's not other things cooking that you could potentially nip in the bud early on, and it's technology that could still help. I think as clinicians, for the biggest thing is we need to have, in order to make a difference in healthcare, we need to have the community trust us again. Because there's so much mistrust based around what's going on. You see all sorts of, particularly there's a rift due to insurance issues, political issues. There's just so much out there, and it's preventing people really from seeking care. And then they seek care only at a point where they absolutely need to. They have no other choice. And at that point, of course, they're going to have an issue because they're very, very far gone. I still get a fair number of people who have never seen a doctor, who don't see a doctor regularly, and some of it's education. And some of it's mistrust, honestly. And I think as clinicians, we need to get out there into the community, and we need to speak to people directly. And we need to tell them what's out there in a way that makes sense. Like when I go to the mechanic to have my car fixed, I think a lot of that hinges on them being able to explain like what's going on. And oftentimes I'll say, like, I don't know, like, I'm not a mechanic, like just fix the car. And that works for a car, but we need to flip that mindset a little bit about our bodies, because I think to make a real difference, we really need to empower people. We need to give them their power back, because a lot of with these large healthcare entities, hospitals, foundations, insurance companies, people feel really disempowered and they don't know who to trust anymore. We need to get out there as clinicians, and we need to tell them what's out there, and we need to be able to educate them about their symptoms, and particularly on the topic of prevention.
Yeah, I so agree. I'm excited to really create awareness and do things like that. I think you're right in terms of, I mean, there is so much mistrust. And unfortunately, when, as you said, women go and they get misdiagnosis, they get dismissed, they say it's a panic attack, or it's, and that's a very vulnerable position for a woman. And a woman then thinks, well, there's nothing wrong with me. I should just accept the way I feel. That's what they're basically saying. And I want to say that is not true. There's always a reason. You can feel when you're in your 50s, because like I am, I know Alex is a lot younger than me, but when you're in your 50s, you can be 30 again. You can actually change your biological age with epigenetics, and it is possible. I'm super excited about where we're going. Maybe when I come out there to San Diego, we can do something together. I don't know, to create some awareness, but I know we talked about maybe something down the road there in May. Thanks so much, Dr. Kharazi, for being here graciously in between working in hospitals, sharing your knowledge, creating awareness for women, especially in heart disease. And I'm so thankful. And hopefully we can keep the conversation going.
Yeah, and I'm really thankful for you, Laura. Like a lot of things cross my path, but very rarely do I see a tool that could potentially be preventative, that could actually narrow that disparity with women specifically. And to that, I will add that women are often still the caretakers. And so they tend to put off their own care as well because they've been culturally sort of taught to prioritize everyone else's care, whether it's their husband, their children, everybody else, and not prioritize themselves. So I think that all the work that you're doing, not only as a women's health advocate in the OB space, but also in the DNA space, really bridges that gap across specialties and helps us bring technology and science directly to the people who need it the most. And so I'm really excited about partnering with you and what we're going to do together. So thank you so much.
Yeah, thank you.